It's a pleasure to introduce Dr. Jean Francis. He's a professor of medicine at Boston University, and he's a experienced nephrologist, a great educator, and I enjoy every year his talk about thrombotic microangiopathies. Jean?
Thank you so much, Jamil, and thank you for the invitation. And we have a busy schedule, so we'll try to cover as much as possible. If anything is left over, you can easily read it and have access to all the information in it. So today I'll be discussing the hemolytic uremic syndrome and TTP. This is the primary focus. We'll definitely cover a little bit the TMA in general. So this is myself. I'm a nephrologist at Boston University, and I have a great interest in thrombotic microangiopathy, in addition to being a transplant nephrologist. Those are my disclosures. So I will start with a case. This is a real case from our practice. This is a 44-year-old previously healthy woman admitted to the hospital with weakness, fatigue, and malaise for a few days. And she had no fever, chills, and no recent travel or sick contact. She reports that a week ago, she developed some upper respiratory viral infection, which resolved in 3 days. She has no known past medical history, and currently she's not taking any medications. Her physical exam, slight increase in blood pressure, a bit tachycardic, maybe borderline low fever, if any. And otherwise, she had normal exam and no abnormalities except for, mild tachycardia. So her blood workup showed that she has AKI, anemia, and thrombocytopenia. Her creatinine is 3.9 from a baseline of 1, platelet 64, hemoglobin 6.8. And PTT and PT are normal, fibrinogen is normal, ruling out any DIC. The workup for anemia revealed that LDH is elevated, aptoglobin is undetectable, Coombs was negative, ruling out autoimmune hemolytic anemia. Schistocytes were also seen on the peripheral smear, and those are significant for what we call microangiopathic hemolytic anemia or intravascular hemolysis. And her serum creatinine continued to increase. It became, it reached 8.5 on hospital day 5. C3 and C4 were normal, ANA and double-stranded DNA. SSA, SSB for lupus detection were also negative. This is the helmet-shaped cells. We call them schistocytes. You need 2 of those or more in high-power field to call it positive schistocytosis. And so what is the underlying, on question 1, pathophysiologic entity associated with this presentation? Is this an autoimmune hemolytic anemia? Is this a thrombotic microangiopathy or TMA? Is this a hemolytic uremic syndrome? Is this a thrombotic thrombocytopenic purpura or TTP? I'll give you a little bit of time to answer. So we are dealing definitely with thrombotic microangiopathy with all the features she has. She has the anemia, she has the elevated LDH, she has schistocytes, she has undetectable aptoglobin, there is organ injury, essentially the kidney. So TMA syndromes are extremely diverse syndromes. They could be hereditary or acquired. They could affect children or adults. Clinically, they are characterized by the MAHA, or microangiopathic hemolytic anemia, thrombocytopenia, and organ injury, exactly what this patient had. The pathology, if you do a kidney biopsy, for example, you're going to see arteriolar and capillary microthrombi and endothelial injury, regardless of the underlying etiology of the TMA. This is exactly what you're going to see. You're going to see severe endothelialosis to the point that the endothelium is so swollen to occlude the lumen. This is the leftover of the lumen. There's microthrombi. In addition to the endothelialosis, you're going to see this onion skinning picture reflective of myocyte muscle proliferation in the media of the arterioles. And this is regardless of the underlying of the etiology of the TMA. So this picture is pathognomonic of TMA, not of a particular disease in TMA. So, and this is a differential diagnosis in the setting of thrombotic microangiopathy that you need to be thinking of and working your skills through every step to try to pinpoint what is the underlying etiology. So we can quickly rule out TTP, especially if your center can check for ADAPT-TS13 and report it fast. And if you check for ADAPT-TS13 activity and it is normal, you rule out TTP, and then you're left over with this variety of secondary TMA versus atypical hemolytic uremic syndrome, what we call now complement-mediated TMA. So it can go, the secondary TMA causes go from infectious, viral, fungal, and bacterial. Strep pneumo is by far the most common etiology of infectious-mediated thrombotic microangiopathy. Parasitic infections, with Plasmodium falciparum. Vaccination can trigger some TMA, especially hepatitis B vaccine. TTP has been reported with this vaccine. Metastatic cancers, breast, gastric, lung, all solid organ cancers, and usually those are severely advanced metastatic cases, and they overlap a lot with DIC. Malignant hypertension for us nephrologists is probably by far the most common etiology, secondary etiology of TMA that we are consulted for. And the pregnancy probably is also common for us. We see with eclampsia, preeclampsia, HELP syndrome, or sometimes even postpartum thrombotic microangiopathy. Autoimmune diseases, they can also trigger thrombotic microangiopathy, and we've seen them all. Systemic lupus erythematosus, antiphospholipid syndrome, scleroderma, and dermatomyositis. Transplant, either bone marrow transplant, which is associated in 20 to 25% of the time with TMA, or solid organ transplant, which usually the occurrence range from 5 to 15% of kidney transplants being complicated by thrombotic microangiopathy, especially depending on the donor and recipient characteristics. Vitamin B12 deficiency can cause a form of TMA we call pseudo-TMA, which is characterized by extremely elevated LDH, and usually it reverses by treating the vitamin B12 deficiency. Severe pancreatitis can trigger TMA, and drugs. A lot of medications. Calcineurin inhibitor by far is what we see in kidney transplant. Gemcitabine, probably you've all seen it, used for GI cancers, can trigger TMA, and drugs on the street, heroin, ecstasy, cocaine, and many other medications listed here. So, you have to go through this differential. You have to use this tree. I call it, it's developed by Carla Nestor. And, if you are able to rule out most of those and you have no other etiology, by exclusion, I think you need to be thinking of atypical hemolytic uremic syndrome or complement-mediated TMA and treat accordingly. So we continue with the case. A kidney biopsy was performed on hospital day 5, which demonstrated active and chronic TMA. So this is a normal kidney biopsy. You can see normal glomerulus, widely open capillary lumens, and this is her kidney. Microthrombi loading all the microcirculation. And this is the electron microscopy showing you severe endothelial swelling and this thickened basement membrane and infiltration by this fluffy white material, all suggestive of chronic thrombotic microangiopathy. So plasma exchange was started on hospital day 5. Hemodialysis also initiated on the same day. Her MAHA thrombocytopenia persisted despite plasma exchange therapy daily for 5 days, and patient remained dialysis dependent. Her ADAPT-TS13 was checked, came back at 78%. That's a very good and normal activity. Her antiphospholipids were negative, and the Shiga toxin was also checked. It was negative. So what is the best next step on this non-responding patient to plasma exchange? Would you continue plasma exchange for another week? Would you start plasma infusion? Would you consider initiation of rituximab? Or would you consider eculizumab, which is a C5 inhibitor and usually indicated for the treatment of atypical hemolytic uremic syndrome? I'll give you a little bit of time to respond. Excellent. It seems everybody agreed that eculizumab is the next best step. So before the administration of eculizumab, you should vaccinate patient for Neisseria meningitidis, vaccinate the patient for Neisseria meningitidis, and start at least 2 weeks of antibiotic prophylaxis for Neisseria meningitidis. Example, you could use Cipro, penicillin is another kind of an antibiotic you can consider. Monitor for any signs of meningitis and treat as needed. No further intervention is needed. Proceed with eculizumab. Okay, and the best answer is You vaccinate, and because they need a period of time to develop their antibodies, at least 2 weeks, during that period, most of our patients are usually covered for prophylaxis against Neisseria meningitis, either with penicillin or ciprofloxacin. A lot of centers would continue that indefinitely as long as they are being treated with complement inhibitor. Some centers stop the antibiotic at 2 weeks. It depends on your center options and guidelines. So to summarize, when we say TMA, patients usually present with thrombocytopenia defined as a drop of platelet count less than 150,000 or a drop of more than 25% of their baseline. They also have MAHA, consistent with, diagnosed with elevated LDH, undetectable aptoglobin, presence of schistocytes on the peripheral smear, and usually anemia. They have one or more of the following organ involvements. Kidney is by far the most common organ involved, especially in the complement-mediated form and the secondary form of TMA. Neuro is probably the most common organ involved in TTP, and gastrointestinal can be involved in all forms of thrombotic microangiopathy. So the first 2 steps is check for ADAMTS13 activity and check for Shiga toxin. If Shiga toxin is positive, this is Shiga toxin-mediated hemolytic uremic syndrome. We'll talk about it. Treatment is usually supportive. If your ADAMTS13 activity, I would say 10%, not 5%, 10%, is less than 10%, you are dealing with TTP. But if your ADAMTS13 activity is more than 10% and your Shiga toxin is negative, you go back to this secondary TMA versus AHUS, and you use this the tree I gave you at the beginning to help guide you navigate the differential diagnosis. Some centers, ADAMTS13 take a long time to come back, and while you're waiting, you have 2 scores you can use to identify if you're going to have a deficiency on ADAMTS13. There's the French score. So if your platelet counts are more than 30,000 and your creatinine is more than 2.25 milligram per deciliter, meaning you have severe renal failure, this rules out TTP by 96% predictive value. So you rule it out with those 2 criteria. If you don't have those criteria, you can use the plasmic score, as you know, and you give a point to each variable. And then, it's a bit confusing in the low and intermediate, but if you score 7, which means you have a very high plasmic score, your probability of having a deficiency on ADAMTS13 activity less than 10% is close to 96%. So on that basis, while you're waiting, you can consider to treat as TTP. So this is very important to remember, the plasmic score or the French score that I mentioned before. What about hemolytic uremic syndrome? It is a form of thrombotic microangiopathy. Usually it manifests with the MAHA, thrombocytopenia, acute renal failure. In its classical form, it is preceded by a diarrheal prodrome associated usually with Shiga toxin producing bacteria. Most cases recover on their own. In its atypical form, may be associated with mutations in complement regulatory proteins. We'll talk about that. And this form has poor prognosis if it is untreated. 50% of patients can reach end-stage renal disease. 25% of patients can die within a year if they are not treated appropriately. And it may recur after kidney transplantation. So treatment and prophylaxis are recommended. What about Shiga toxin HUS? It is usually induced by enteric infection with Shiga toxin secreting strain of E. coli, 0157 or 0104, or sometimes Shigella. Usually they come from contaminated water, vegetables. In Europe, last few years, a big epidemic happened from Brussels sprouts. And sometimes beef products can be also undercooked beef products could be the etiology. It is common in children, usually presents with AKI. 6 to 9% of the Shiga toxin infected children develop HUS. Not everyone infected will end up with the Shiga toxin HUS. And it is usually bloody diarrhea is the prodrome 5 to 10 days before they present to you with the AKI. 60% will require dialysis when they develop their AKI, and the mean time on dialysis is 10 days. 25% of the affected patients will have neurological symptoms, and this is usually the severe form of Shiga toxin mediated hemolytic uremic syndrome. 5 to 25% will end up with long-term kidney morbidities like hypertension, persistent proteinuria, a drop in their EGFR, Treatment for this disease is supportive. The role of plasma exchange and complement inhibition is really uncertain. There's some data that does not support it. Some data support severe cases being treated with complement. But as of now, there is no agreement on any role for those therapies in Shiga toxin-mediated hemolytic uremic syndrome. So how does this pathophysiologically work? So, once the Shiga toxin makes it into the bloodstream, it binds to the GB3 receptor expressed on the platelets or the leukocytes, and then it is driven to the kidney and released in the kidney and bind on the GB3 receptor on the surface of the endothelium. And from there, it gets internalized, goes into the endoplasmic reticulum, and then gets excreted and bind to the ribosome and blocks protein synthesis. And this healthy anticoagulant, anti-inflammatory endothelium shifts upon damage by the Shiga toxin to a pro-inflammatory, pro-coagulant, and apoptotic proteins are highly expressed, leading to the death of the endothelial cells, expression of the subendothelial surface, which activate platelet aggregation and thrombi formation and acute kidney injury. So this is the pathophysiology of the syndrome. Which of the following statements is correct? Normal complement levels rule out AHUS. The absence of complement system-related genetic mutations rules out AHUS. The absence of family history of AHUS rules out AHUS. Or none of the above. I think there's a delay between when you click, guys, and when I see you. And this is the answer, none of the above. So neither normal complement or absence of complement mutation or absence of family history, none of those rule out the possibility of AHUS. Sorry. So what is atypical hemolytic uremic syndrome? It is usually not, it has nothing to do with Shiga toxin. It's not induced by Shiga toxin. It is often recurrent. 50% of patients have normal complement level and normal soluble MAC, if you check them, may cause permanent kidney damage, may cause neurologic and other organ damage, frequently recurs after transplantation. It is usually may be sporadic or familial, and it is linked to abnormalities of the complement regulation, specifically of the alternative pathway complement regulation. And this is a picture of the complement system. As you know, it can be activated via the classical pathway, the lectin pathway, or the alternative pathway. This is our focus. And there are some principles you need to know. Alternative pathway is constantly ticking in all of us at low level all the time. And if there is a trigger, it will tick even more and more aggressively. And there is always active byproducts like C3b or the C3b big B little b, which is the C3 convertase, or even the C5 convertase, which are usually produced and deposit on the surface of the endothelium, and they can activate the complement on the surface of the endothelium. So imagine if we don't have a way to defend ourselves from those active byproducts, we can end up with damaging the endothelium and ending up with AHUS. But thankfully, most of us, we have regulatory proteins either circulating like factor H and factor I, or even expressed on the surface of the endothelium like thrombomodulin and MCP. As soon as an active byproduct of the complement deposit on the surface of the endothelium, they come together, degraded, and protect us. And this is why we don't develop AHUS. But imagine you have a deficiency or dysfunction of any of those regulatory proteins, and then you have an hyperactivation of the alternative pathway, you could end up with atypical hemolytic uremic syndrome. And the most common mutations reported are mutations affecting complement factor H. They represent almost 25% of the etiologies of AHUS, and 90% of those mutations and more are located in the short consensus repeat 19 and 20 in the C-terminal part of the factor H, and those are very important for the binding of factor H on the surface of the endothelium to execute its regulatory activity. If it cannot bind, it cannot work. Other mutations could affect factor I, which is a serine protease that degrades active byproduct of the complement. There are gain-of-function mutations that can affect C3 and complement factor B, rendering them resistant to the decay activity of factor H and factor I. As I told you, two proteins expressed on the surface of the endothelium, MCP, and the thrombomodulin are also responsible of some of the atypical hemolytic uremic syndrome cases. And sometimes we have no mutation. What we have a circulating anti-complement factor H antibody seen in 6 to 10% of the cases. This antibody can bind to short consensus repeat 19 and 20 and block the factor H activity. So if you are to take 100 patients with AHUS who have like well-proven AHUS, and you do a genetic testing on them, 50 to 60% of them are going to have mutations. The remainder have no mutations in any of those regulatory proteins. So there's other hypotheses what could be causing that AHUS, but still there's a lot of area of research trying to figure out what is going on in those patients. Not all mutations are equal. Factor H and I mutations are the most severe in leading to end-stage renal disease over time, untreated. And MCP usually is more benign compared to other mutations leading to AHUS. There is an incomplete penetrance of those mutations. This is a family from Italy. You can see two kids developed AHUS at a very young age and died from it. Their brother at age 4 developed AHUS and ended up on dialysis. They all carry the same mutation, labeled with the asterisk here. Their father carries the same mutation, never developed AHUS. Their grandfather, carrying the same mutation at age 82, he developed AHUS and died from his AHUS. So you can tell this highly variable penetrance of those mutations. So to summarize, atypical hemolytic uremic syndrome may arise when there is deficiency, dysfunction, or antibody-mediated inhibition of one or more of the regulatory proteins, or if there is a resistance of C3b or factor B. We call this gain-of-function mutation, making them resistant to the decay activity by factor H and factor I or MCP, or there is a mutation of thrombomodulin, which is an endothelial glycoprotein which plays a cytoprotective effect that can degrade complement byproducts, and it has an anticoagulant property. But this is the most important piece. The disease may be quiescent for months or years, even in patients with homozygous mutation and complete deficiency of a regulatory protein, only to be triggered by otherwise innocuous infection, drug exposure, pregnancy, surgery, you name it. A trigger can be anything. Drug exposure. So regardless of where is the mutation in C3 and factor B and factor H, if you have a drug that can bind to C5 and prevents the splitting of C5 into C5b and C5a, C5a, as you know, is a very potent chemoattractant that can cause severe inflammation, and C5b is essential protein that will generate the membrane attack complex. If you can prevent the splitting of C5, either by using eculizumab or ravulizumab, which are the two approved, FDA-approved drugs for the treatment of AHUS, you can halt the terminal the activity of the terminal cascade of the complement and treat the disease. And those medications have been trialed. And in this trial, patients were maintained on plasmapheresis all their life because of their AHUS, and they were resistant. They were persistently anemic, thrombocytopenic. And if you look, 100% of them had GFR less than 60 ml per minute. When they, at the end of the 26 weeks of treatment period with eculizumab, GFR went up by 32 ml in those patients, and 4 of 5 patients were able to discontinue dialysis. Even the patients who were responding to plasmapheresis, but they were getting plasmapheresis 3 or 4 times a week, when they shifted them to eculizumab, at the baseline, 90% had GFR less than 60, and you can see that GFR went up by 6 mLs per minute at the end of the trial period. And both groups had a very good improvement in their health-related quality of life. They're not anymore bound to plasmapheresis and dialysis-like machines. But remember, when you block C5, you put patients at high risk of infection with encapsulated bacteria, strep pneumo, Neisseria meningitidis, or even Haemophilus. And the most fearsome one of them is the Neisseria meningitidis. Patients have to be carrying this card with them to alert any treating doctor in any emergency room that they are on complement inhibition therapy. And those are the symptoms. They need to be educated about the symptoms of Neisseria. And as I said, vaccinate, cover for 2 weeks at least with antibiotic, and then you can stop it or continue it indefinitely depending on the guideline of your center. The disease has high recurrence rate after the transplant, and if it recurs, high risk of organ loss. Look at that, up to, from 80 to 100% of the kidneys will be lost. So you could ask why MCP should recur. We know it recurs in 15 to 20% of the time. If we're giving a kidney with normal MCP expression, it should protect it from recurrence. That's true. But MCP mutation overlap with other factor mutations like H, I, or factor B in 20 to 25%. So genetic testing is very important before you transplant to rule out any overlapping mutations. Then this is how we treat our patients. If they're receiving a kidney transplant from living donor, we start the treatment a week before the surgery. On day of surgery, we continue it weekly for 5 times, and then we shift to every 2 weeks. If they're receiving a cadaveric kidney, we give it the first dose in the OR. The second dose is given 24 hours after the surgery, because this is the period of the highest activation of complement that you want to block and prevent recurrence. And then we give it weekly with a total of 5 doses, and then we shift to every 2 weeks. Can we stop eculizumab after you use it? Yes. If you use it for 6 months, you can do genetic testing. If patients have any genetic mutation, the risk of relapse is 50%. So you have to be considerate if you want to stop it. If you stop, you need to monitor. And if they are to relapse, you resume C5 inhibition. But if you have no genetic mutation, the risk of relapse is less than 5%. So those you can easily stop and monitor. If there is any relapse, you resume C5 inhibition. Okay, this is a 12-year-old male patient who developed ESRD secondary to HUS. He is now undergoing an evaluation for kidney transplantation at your center. Which of the following statement is correct? Living unrelated kidney donor should be avoided. Living related kidney transplant should be avoided. He can be transplanted regardless of the source of the donor as long as he received eculizumab after kidney transplantation. The risk of recurrent HUS after kidney transplantation is very low. So living-related kidney transplant in a lot of centers is avoided, but now with the presence of genetic testing, probably you could say, if I know the genetic mutation of my recipient, and if somebody in his family wants to donate, I can test them. If they carry the same mutation, they are excluded. If they don't carry the same mutation, we can proceed. A lot of centers apply that, and some centers totally deny living-related kidney transplant. And this is an example. This is real case example. This is a sporadic HUS in a young man, 20 years old, received a kidney transplant from his father. 1 year later, the father developed HUS. So genetic testing between donors and recipients is very important when they are related. Like you need to pinpoint a mutation if it is present or not. And remember, most of the complement factors are synthesized in the liver, so liver and kidney transplant combined could be a treatment in certain centers. If patient decides they don't want to be on medication for life or for any time to block the complement, you can consider a combined liver-kidney transplantation. It's very complicated surgery to do in the setting of AHUS, but it's feasible in very selected centers and centers with expertise. And just to give you a highlight of a lot of new complement agents that are going to be on the market soon, that are being trialed in all areas of nephrology. And, this is a case of 10-month-old male infant presents with MAHA, thrombocytopenia, and AKI. He has no known family history of AHUS. The patient had persistent hypertension, hematuria, and importantly, nephrotic range proteinuria. That's very unusual for complement-mediated TMA. All genetic complement testing were negative. A kidney biopsy was performed, and all what you see is a very thickened basement membrane and swollen endothelium, all suggestive of active thrombotic microangiopathy. So what is the most likely diagnosis? Is this a complement-mediated AHUS? Is this a TTP? Is this an HUS secondary to deacylglycerol kinase mutation, DGKE mutation? Or is this a lupus nephritis? getting short on time here. This is a DGKE mutation. There are pathognomonic features. It is responsible of 27 to 30% of the AHUS that happen in the first year of life. And usually patients have nephrotic range proteinuria or like nephrotic syndrome. It is not complement mediated. It is not treated with complement. It is not going to respond to complement inhibition. Usually the treatment is a transplantation. Okay, Jamil, how are we doing? Not good, huh? You usually give me more time. Now you're giving me Dr. Dariella time. So I should get like 5 minutes extra. So TTP. It was described in 1924 by Moskowitz. It is associated with central nervous system involvement. And it remained a mysterious disease until identifying the etiology in 1980s. And this is based on the presence of those large von Willebrand multimers circulating in the blood. So it has a pentad, but we usually don't see the pentad. They have severe thrombocytopenia, usually below 30,000. They have MAHA. They have essentially neurological involvement, although it is absent in 30% of the time. And they have renal failure, usually not severe. And they can have also fever. And as you know, von Willebrand factor is a large glycoprotein. Usually it's synthesized as dimers, and then it multimerized in the Golgi apparatus. And this is the functional form when it is excreted, and it can really activate the platelet aggregation and coagulation system. But, you know, thankfully we have ADAMTS13 that is constantly secreted, and it can degrade those multimers and preventing us from developing those aggregates of platelets and TTP. So TTP exists in two forms. It could be hereditary, where you have a homozygous or compound heterozygous mutation, either leading to absence of ADAMTS13 or dysfunctional ADAMTS13. This is a childhood disease, and it can, in certain cases, manifest in young women during pregnancy in milder form. And patients who are heterozygous have normal function of their ADAMTS13, and they don't develop TTP. So what happens, this is the multimers, and the von Willebrand factor binds to the A2 domain on the multimers of von Willebrand and degrades them into the smaller, shorter multimers that are not able to activate the platelet. Imagine you have absence of ADAMTS13. This would lead to aggregation of platelets and activation on those persistently present multimers. And the treatment is you have to give them ADAMTS13 either via factor VIII concentrate, which is super rich in ADAMTS13, via plasma, or often you can also use recombinant ADAMTS13. And, those kids don't do very well. In the acquired form, it has a variable presentation. Usually it can present with weakness, GI symptoms, purpura, focal neurological deficits. Usually they have normal or transient mild renal failure. Third of patients will have no neurological finding. And in those cases, you will find a reduced activity of ADAMTS13 below 10%, which is usually caused by the presence of an autoantibody blocking the ADAMTS13 activity or accelerating its clearance. And this is, when they test for the activity, then they look for the inhibitor. And if the activity is low, they will identify the inhibitor. Again, this is normal function, but if you look here, if you have an antibody that can bind to ADAMTS13, either blocking its activity or accelerating its decay, the same. The multimers would remain on the surface of the endothelium, activate the platelet and the coagulation system, leading to microthrombi everywhere, essentially neuro, sometimes the kidney, and this could lead to TTP. So treatment is a plasma exchange. Please remember that. Without a plasma exchange, mortality is 90%. Survival is more than 90% if you do plasma exchange. A lot of patients will require steroid, relapsing form, or recalcitrant form, or require rituximab, and many other immunosuppressants have been also used. So adults with TTP and plasma exchange removes, usually plasma exchange will remove the von Willebrand factor and also will remove the antibody that is blocking ADAMTS13, and the plasma usually infuses us with a new ADAMTS13 that is functional. As I told you, survival is more than 90%. We use steroids all the time to reduce the inflammation seen at the site of those macroaggregates of platelets. Rituximab also is often used for severe cases, and especially if there's neurological symptoms, to get rid of the inhibitor. And aspirin or anticoagulants may increase the bleeding risk, and platelets transfusion can be used in severe thrombocytopenia. So avoid unnecessary anticoagulation. And I will stop here, Jamil, after this slide. The case they can read on their own. It's very easy and well explained. So as I said, the treatment essentially is a plasma exchange and associated with recombinant ADAMTS13, especially in the Upshall-Schulman syndrome, where there's a hereditary deficiency of this. Glucocorticoids and rituximab are the treatment of choice. If they are resistant, there are case reports of vincristine, cyclophosphamide, splenectomy, bortezomib. They all have been used. Eculizumab, there are some case reports of overlapping, if you want, activity of TTP and HUS at the same time. And in centers where plasma exchange is not available, you can use caplacizumab, which has been approved for urgent therapy of TTP. It blocks the binding of platelets via the A1 receptor on the von Willebrand factor, and this can block any aggregates from occurring. And it is recommended either to use it as a supplement to the plasma exchange or in places where there is no plasma exchange. Be careful, it can cause bleeding. And I would stop here because the case is easy to read on your own. And thank you so much for your time and attention. Please let me know if you have any questions. Thank you, Jamil, for the extra time.
Yeah.
Appreciate it.
So well noted now. You took extra 5 minutes for next year. Thank you, Jean, for an amazing